Most definitely with the case reviews, speaking on cardiac patients, stroke patients. Remember the phrase time is tissue. So if we don't diagnose you quick enough, we're in trouble. So it's being able to identify who's in our lobby, who's in the waiting room waiting to see a physician. They have multiple complaints. And you have to, we're the experts, the patients are not. And so they'll give us tons of symptoms that they may be having, but we have to be able to differentiate that timely in order to meet their needs and to have better outcomes. So speaking to them about those quality outcomes, so studies have shown if we don't reperfuse your arteries within 60 to 90 minutes, we're going for 60. I believe national standard is 90. Right, but we're going for 60 minutes. If we don't reperfuse your arteries, your chances of leaving out the way that you came in, in good condition, able to go out and run and jog with your kids, is slim to none if we don't do that timely. So timeliness is quality. We tackled left without being seen initially, and that was focusing on the front end, changing that traditional triage process to a quick look, sorting the patient versus a tedious process, again, of non-value added steps. Decreasing the questions that we ask when it comes to registering you, not asking for your address or to confirm any of your demographics, solely name, social security number, just so you can pop up, those type things so we can get you in the system faster. And again, shifting those mid-level providers to the front captured those patients that were leaving without being seen. Think about the perception of the patient. I've seen the doctor. I've seen the mid-level provider. I'm being treated. And that perception alone keeps our patients here and have decreased our left without being seen from about 12.9% to 6.9%. Well, it has streamlined things for them, but this is a cultural change. So now we're working with a group of nurses that have been doing things one way for so long. And so it's very important that we work with them off scene. When I say off scene, not out on the unit, we have to make sure we work on process improvement initiatives outside of here. Training is key and buy-in is key. And so we have to give them that those evidence-based studies and practices to tell them what others are doing and how we need to meet the same standard. Yeah. So evidence-based practices, like we're not the first ones to have done this. We've definitely replicated what we've learned as well. And so taking that evidence-based and then tailoring that to Hahnemann, tailoring that to your emergency department. What works for your team, what works for your patient population is key. So we have what we call right now at this particular institution a plan of the day, because things change. Our acuity levels change in the emergency department, our staffing skill level changes, and so does our physician. Right? And so that kind of change from day to day. What we try to give them, or what we do give them, is the basic principles of the processes and allow them to tweak it to what work best for them. It is definitely a team approach, so everyone has to have their input.